Okay, somehow it worked out. Somehow it worked out and it came somehow. Acha. And I wanted to edit the name of it. Okay. Edit. Title. Reading out loud. I would say on Saturday, 25th Feb. Save. Okay, that will do. Okay, after a good amount gap, here I am. No problem, you can resume, restart anytime that you want. Yes. Today I want to do the entry and then start with my first Pomodoro of the day. Yes. 25th of Saturday. So now to finish the first Pomodoro and then into the breakfast. Okay. So that is long about hepatitis B virus. Can I just yeah. Virology and pathogenesis. Hepatitis B virus. So let me just at this time. Hepatitis B virus. Virology and pathogenesis. Hepatitis B virus, a member of family Epidemiviridae, consists of 42 nanometer diameter spherical particles with 3.2 kilo base pairs, partially double-stranded DNA genome. The viral genome has four genes, namely S, C, P, and X, which code for viral surface protein, also known as hepatitis B surface antigen, hepatitis B core protein, viral DNA polymerase, and a protein of unknown function, hepatitis B X protein, HBxAg, respectively. The blood of HBV infected person in addition contains spherical and cylindrical structures measuring 22 nanometer in diameter. These represent excess HBsAg but do not contain viral DNA and hence are incapable of causing infection. HBC antigen is expressed on HBV infected hepatocytes but is not detectable in the blood. The C gene also codes for another protein known as hepatitis B E antigen HBeAg, which is secreted into the blood and is considered as a marker of high rate of viral replication. HBeAg antigen, high rate of viral replication. At least 8 genotypes named A to H are known. Of these genotypes, G and A are the predominant types in India. HBV replicates through an RNA intermediate using a virus encoded DNA polymerase, which also has a reverse transcriptase activity. In immunocompetent persons, HBV is not cytopathic and liver damage is mediated by host immune response directed against HBV infected cells. However, in organ transplant recipients with immunosuppression, liver cells may show cytopathic effect caused by presence of virus in large amount. Epidemiology: hepatitis B virus is transmitted mainly by bloodborne, that is parental routes, such as transfusion of contaminated blood and blood products, intravenous drug use, hemodialysis, sexual contact, percutaneous exposure, needle stick injuries, shared razor blades, toothbrushes, tattooing, acupuncture, etc. Transmission can also occur from HPV infected mothers to their newborns around the time of delivery. Perinatal transmission. This risk is higher in mothers who are also HBeAg positive or have high viral load, usually taken as more than 10 raised to 6 international unit per ml. In India, a majority of chronic HBV infections are acquired horizontally, and fewer than 20% of chronic HBV infections result from mother to child transmission. Hepatitis B virus is the second largest cause of acute viral hepatitis and hepatitis E virus among adults in India and accounts for 15 to 30% of such cases. Acute hepatitis B is more common in persons with parental risk factors such as injection drug use, unsafe injection practices following blood transfusion or surgery, etc. However, in many cases, no risk factor can be identified. Clinical presentation and course. Incubation period is 45 to 180 days. The outcome of HBV infection is heavily dependent on age. In adults, nearly two-thirds of new infections are subclinical and about one-third lead to icteric hepatitis. At younger age, the frequency of disease is lower. Thus, most infections in infants, including perinatal, are asymptomatic. About 1% of patients with acute hepatitis B develop acute hepatic failure. 1%. In acute hepatitis B, viremia lasts for a few, usually less than 12 weeks after the onset of symptoms. Infection persisting beyond 6 months is labeled as chronic HBV infection. The risk of chronic HBV infection depends on age at time of infection. Thus, nearly 90% of neonates, 30 to 50% of young children aged 1 year to 5 years, and only 1 to 5% of adults with acute HBV infection develop chronic infection. The risk of chronic HBV infection is also higher among immunocompromised persons such as those with HIV infections, those receiving immunosuppressive drugs, and those on repeated hemodialysis. Diagnosis: several HBV antigen and antibodies to them and HBV DNA can be detected in serum or liver tissue. Diagnosis of HBV infection is most often made by detection of circulating HBsAg found in both acute and chronic infection, presence of IgM antibodies to HBC core antigen, IgM anti-HBC indicates a recent acute HBV infection and helps differentiate between acute and chronic HBV infection. IgG anti-HBC antibodies appear soon after exposure to HBV and persists for years, usually lifelong, irrespective of whether the infection has been cleared or is persistent. Hence, their presence is a good marker of clear exposure to HBV. Anti-HBs antibodies appear with the clearance of HBV infection and suggest complete recovery. These antibodies, but not anti-HBC, also appear after successful vaccination. Detection of IgG, anti-HBC, and anti-HBs antibodies has no role in diagnosis of acute hepatitis B. In chronic HBV infection, presence of HBeAg in blood suggests active viral replication. It is absent in persons with low-level viral replication, as also in some patients who are infected with a mutant HBV that lacks the capability to produce HBeAg. Detection and titer of HBV DNA in blood using polymerase chain reaction helps determine the presence and rate of viral replication. This helps in assessing the need for and the response to antiviral treatment. Detection of viral mutants needs specialized tests such as DNA amplification, sequencing, assays for quantitative measurement of HBsAg, and detection of HBV RNA and intermediate produced during viral replication are available. However, their exact role in various clinical settings is still uncertain. Treatment: acute HBV infection in adults is mostly self-limiting disease. It does not need any specific antiviral treatment. Follow-up HbA1c testing at 6 months is advisable. Continuing positive results indicate chronic infection. Patients with acute liver failure, protracted severe manifestations, or an immunosuppressive state may benefit from specific inhibitors of HBV DNA polymerase. These agents, nucleotide and nucleotide analogs such as lamivudine, entecavir, tenofovir, are administered orally and have little side effects if any. Patients with chronic HBV infection need a more detailed evaluation for determination of the state of disease and the need for antiviral treatment. Prevention: hepatitis B virus infection can be prevented by screening the transfused blood and blood products for HbSAg using single-use needles and syringes, taking precautions against nosocomial transmission, and practicing safe sex barrier methods. Subunit vaccines that contain the viral surface protein HBs antigen highly effective in preventing HBV infection, though initial vaccines were derived from plasma persons with chronic HBV infection. Most of the currently available vaccines are recommended. 3 doses at 0.16 months, usually 20 microgram each, induce protective antibodies in more than 95% of the recipients. Adverse events are rare except for local pain and swelling. HBV vaccination has been shown to reduce chronic HBV infection rate and the incidence of hepatocellular carcinoma. The vaccine is included in India's national immunization schedule, 3 doses at 6, 10, 14 weeks, and birth within 24 hours of birth where possible for hospital deliveries. Otherwise, it is 6, 10, and 14 weeks. For those who need a rapid protection, those at high risk of infection or recent exposure, needle stick injury, 0, 1, 2 month schedule followed by a fourth dose at 12 months is recommended. Hepatitis B immunoglobulin is useful for post-exposure prophylaxis when administered soon, that is within 48 hours after exposure, or newborns of HBeAg positive HBV infected mothers. That means the mother should have an active infection if you are administering this immunoglobulins. Hepatitis C virus, virology and pathogenesis. Hepatitis C virus, a member of family Flaviviridae, has small 55 to 65 nanometer enveloped virions with a linear single and positive strand 9.5 kilobase RNA genome with a single open reading frame. The polyprotein undergoes cleavage to produce various viral structural and non-structural proteins. At least 6 genotypes are known. In India, genotype 3 is the most prevalent, followed by genotype 1. Only occasional cases of other genotypes. HCV genotype determines the response to some anti-HCV drugs. The exact mechanism of hepatic injury in HCV infection is unknown, and post-immune responses appear to play a role. Though HCV infection leads to induction of anti-HCV antibodies, they later have no role in clearance of HCV infection or protection against reinfection. Epidemiology. Hepatitis C virus circulates in blood of infected person and is transmitted by blood-bound routes. Its transmissibility is much lower than that of HBV. Risk groups for HCV infection include recipients of blood and blood products, persons who inject drugs, and those on maintenance hemodialysis. Sexual and perinatal transmission can occur but are infrequent. Thus, fewer than 5% of long-term sexual partners of HCV infected persons and infants of HCV infected mothers have HCV infection. Similarly, risk of transmission following needle stick injury from HCV infected persons to healthcare workers is very low. In India, transfusion of blood and blood products prior to the introduction of anti-HCV antibody screening in blood banks or nosocomial exposure are the major risk factors identified among HCV infected persons. Worldwide prevalence of HCV infection is around 1% with marked geographical variation. Anti-HCV antibody prevalence rate in India is around 1% with active infection in 60 to 75% of the seropositive persons. HCV is responsible for 20 to 30% of patients with chronic liver disease in India. Clinical presentation and course. Incubation period of HCV infection range from 15 to 160 days. Acute HCV infection is typically asymptomatic and acute viral hepatitis like clinical illness is infrequent. Hence, in most persons, the initial phase of HCV infection goes unrecognized. The occasional persons with symptomatic infection are more likely to clear the infection. Fulminant hepatic failure due to HCV infection is extremely uncommon. A majority, 50 to 85% of HCV infected persons develop chronic infection defined as persistence of virus for longer than 6 months. Spontaneous resolution of chronic HCV infection is infrequent. Chronic HCV infection is associated with histological evidence of chronic hepatitis and high risk of developing complications such as cirrhosis and hepatocellular carcinoma, often 20 to 40 years after acquisition of infection. Eventually, liver-related death. Diagnosis of HCV infection is usually made by detection of anti-HCV antibodies using third generation enzyme immunoassay. Laboratory distinction between recent and long-standing HCV infection is difficult, and most of the seropositive cases have chronic infection. Since a proportion of HCV infected persons clear the virus spontaneously, the presence of antibodies does not necessarily indicate active infection. This needs demonstration of HCV RNA, usually using an amplification, reverse transcription, and polymerase chain reaction assay. Anti-HCV antibody may be undetectable in some immunosuppressed persons, those with HIV infection or chronic renal failure, or in the initial few weeks after acquisition of infection. In such cases, detection of HCV RNA can be helpful. Treatment. Chronic HCV infection needs treatment to prevent long-term complications. Till 2014, a combination of interferon alpha or pegylated interferon alpha with ribavirin was the standard of care till 2014. So your just let me just this one till 2014. A combination of interferon alpha or pegylated interferon alpha with ribavirin was the standard of care. These regimens had suboptimal response rates, needed injections, and had frequent major adverse events. Now, several orally administered drugs known collectively as direct acting antiviral agents DAAs that specifically inhibit one of the HCV proteins, namely protease NS3A protein, replication complex NS5A protein. As we studied further, like before already, as we studied, we knew that HCV is producing many structural and non-structural proteins. So here we are targeting. So how we are targeting one of the HCV proteins, namely protease and replication complex. So protease is NS3A protein complex and replication complex is NS5A protein, and RNA dependent RNA polymerase, which is NS5E protein. So this you have to remember in your mind. Regimen-based combinations of directly acting antiviral agents are highly effective with cure rates exceeding 95%. Further, the directly acting antivirals have very few adverse effects. The choice of DAA regimens is often based on viral genotype. Though pan-genotypic drugs are also now available, many directly acting antivirals, though very costly in developed countries, are quite cheap in India. A needle stick injury from an HCV infected person, only laboratory monitoring for HCV infection with no post-exposure prophylaxis is recommended. Previously, interferon-based treatment was advised for acute hepatitis C if the virus was still detectable at 12 weeks. For DAA-based drugs, indications for treating the acute hepatitis C are still evolving. So for needle stick injury from HCV infected person, only laboratory monitoring for HCV infection with no post-exposure prophylaxis is recommended. Previously, interferon-based treatment was advised for acute hepatitis C if the virus was still detectable at 12 weeks. For DA-based drugs, indications for treating acute hepatitis C are still evolving data. Okay. Prevention: use of voluntary blood donors as opposed to professional donors and screening of donated blood for anti-HCV antibodies is an effective method to reduce HCV transmission. Nosocomial transmission can be prevented by attention to injection safety, including the use of disposable syringes and needles. Active or passive immunization against HCV infection is not available. That you have to remember. Hepatitis D virus virology. Hepatitis D virus is an incomplete virus, that is, it needs the presence of another virus, that is HPV, within the same cell for its life cycle. It consists of nearly 36 nanometer enveloped spherical particles with a small circular single-stranded RNA genome of 1700 nucleotides. Its outer coat consists of surface protein of HBV, since HDV genome lacks a genome for its own core protein. Epidemiology: hepatitis D virus infection is prevalent worldwide, however, its frequency has declined globally over the past 2 to 3 decades. In India, studies in HBV infected persons suggest that HDV infection is infrequent. Transmission of HDV occurs primarily by parental routes through contaminated blood or blood products and unsafe injection practices. Clinical features and cause: infection with HDV may be acquired simultaneously with HBV, known as HDV co-infection, or by exposure of a person with prior chronic HBV infections to HDV superinfection. The natural history and outcomes of these two forms of HDV infections are different. HBV and HDV co-infection causes an acute illness which is somewhat more severe than acute HBV monoinfection. It is generally associated with complete clinical recovery and clearance of infection in 80 to 90% of the patients. HDV superinfection in chronic HBV infected person leads to acute deterioration of liver function and may resemble acute viral hepatitis clinically. However, by contrast with co-infection, most persons with HDV superinfection develop persistent HDV infection. Such chronic HDV dual infection is associated with an increased rate of progression to cirrhosis, decompensated liver disease, and hepatocellular cancer compared to chronic HBV infection alone. So, how do you diagnose? Diagnosis of HDV infection is made by demonstration of anti-HDV antibodies using enzyme immunoassays or HDV RNA using reverse transcriptase using reverse transcription polymerase chain reaction in serum or liver tissue, whereas antibodies can persist even after infection has been cleared. HDV RNA detection indicates current infection. Okay. IgM anti-HDV tests do not reliably distinguish between acute and chronic infection. Presence of IgM anti-HBC indicates recent HBV-HDV DNA, HBV-HDV Co-infection. Presence of IgM and HBC indicates the recent HBV-HDV co-infection, and its absence indicates HDV superinfection. So co-infection, superinfection, how to investigate and have a clue is IgM and THBC. If it is present, it indicates co-infection, like both HBV and HDV occurring. But if it is absent, that means already patient had HBV infection. Over that, there is HDV infection, that is super infection. Treatment. Interferon-based therapies are the only option, but with a low response rate, approximately 25%, and a frequent relapse and stopping treatment. Efforts are on to develop newer drugs, including inhibitors of prenylation of viral entry into the cells and of HBsAg release. Interferon-based therapies are the only option, but with a low response rate, approximately 25%, and frequent relapse and stopping treatment. Efforts are on to develop newer drugs, including inhibitors of prenylation of viral entry into the cells and of HBsAg release. Prevention. Hepatitis D virus can be prevented by avoidance of parental risk factors and preventing HBV infection, including through the use of HBV vaccine. Hepatitis E virus, virology and pathogenesis. Hepatitis E virus virions are 32 to 34 nanometer diameter, non-enveloped icosahedral particles with positive and single stranded 7.6 kilobase RNA genome. Human isolates of HEV belong to four main genotypes. Genotype 1 is common in India. Other Asian and African countries. Genotype 2 has been reported from Mexico and some parts of Western Africa. Genotype 3 is prevalent all around the world, circulating naturally in many mammalian species, in particularly pigs, deer, and wild boars, with occasional zoonotic transmission to humans reported primarily from Europe, United States, and developed countries of Asia Pacific, Japan, South Korea, Australia. Genotype 4 hepatitis E virus resembles in genotype 3 in causing infection among animals with occasional human cases, but is limited to China and Southeast Asia. The virus binds to unidentified cell surface receptors on hepatocyte surface. After entry into the hepatocytes, its genetic material is released in the cytoplasm where viral proteins are synthesized, following by replication of hepatitis E viral RNA. The newly produced virions enter the bile to be excreted in feces. The mechanism of liver injury remains unclear. Epidemiology. Hepatitis C virus has fecal-oral transmission, usually through contamination of water supplies. It is most common cause of acute, sporadic, and epidemic viral hepatitis in India. Majority of these epidemics have been caused by contamination of drinking water by sewage. This can occur due to backflow during floods, contamination of well water during rainy seasons, and leaking sewers located close to corroded drinking water pipes. Person-to-person transmission of hepatitis C virus is infrequent. Transmission through blood transfusion and from pregnant women to their newborn children can occur, but these groups account for only a minute proportion of all infections. Similar patterns is seen in many other countries of Asia and Africa. In these areas, human disease is caused by genotype 1 or 2 hepatitis E virus infection. The disease most often affects young adults in the age group of 15 to 35 years and is infrequent in children. Incubation period varies from 2 to 10 weeks. A different epidemiological pattern is seen in Western Europe and North America and developed countries of Asia, Japan, South Korea, etc. In these areas, only occasional cases of hepatitis E are encountered. These are related to zoonotic transmission of genotype 3, less often 4. Hepatitis E virus through consumption of undercooked contaminated animal meat or close contact with animals. In India, hepatitis E virus isolates from animals and humans have belonged to separate genotypes of 4 and 1, respectively, indicating that zoonotic transmission is infrequent. Not as frequent. Clinical presentation and course. As with other hepatitis viruses, clinical manifestation of HEV infection range from asymptomatic to icteric hepatitis to acute hepatic failure. Some patients develop prominent cholestasis with marked jaundice and itching and lasting for a few months. HEV infection in pregnant women, especially during second or third trimester, is associated with higher risk of symptomatic disease, development of acute liver failure, and mortality. This association is a characteristic feature of HEV infection in high endemicity areas of Asia and Africa. However, it is not seen in low endemicity areas with genotype 3 HEV infection. Chronic infection with genotype 3 HEV has been described as in immunosuppressed persons with low endemicity areas, Europe, USA, etc., and can progress to cirrhosis. Diagnosis. Epidemiologic characteristics. The occurrence of clusters of cases with acute viral hepatitis among adults without parental risk factors in a high endemicity area suggests the diagnosis of hepatitis E. This is particularly likely if pregnant women are disproportionately affected. A positive test for IgM anti-HEV antibodies, a marker of recent HEV infection, is confirmatory. IgG anti-HEV antibodies appear almost simultaneously but persist for a long duration. Hence, their presence indicates exposure, either recent or past, and is used for sero-epidemiologic studies. Anti-HEV antibodies and protection against reinfection appear to wane with time, becoming undetectable over years. HEV infection can also be diagnosed by detection of HEV RNA. However, this is cumbersome and is used primarily in low endemicity areas and for diagnosis of chronic HEV infection. Treatment. No specific drugs are available and advisable for acute hepatitis E. No specific drugs available and advisable for acute hepatitis E. Chronic hepatitis E caused by genotype 3 or 4 HEV in immunosuppressed persons responds to reduced immunosuppression in about one third of the cases. In the remaining cases, 3 to 6 months of treatment with ribavirin or interferon alpha has shown good results. Prevention. Hepatitis E virus infection can be prevented by steps aimed at interrupting fecal-oral transmission, such as safe disposal of human feces, provision of safe drinking water and food. Subunit HEV vaccine that contains a recombinant protein corresponding to a part of viral capsid protein and was shown to be effective, protective efficacy of approximately 95% in field trial, is available in China. However, it is not approved for use in India. Passive prophylaxis using immune serum has no role in preventing HEV infection. Next on we have chronic viral hepatitis, written by our respected Dr. Radha K. Devan and Dr. Madhumita Premkumar. Chronic viral hepatitis refers to hepatic inflammation or necrosis of varying severity due to infection with hepatotropic viruses such as hepatitis B virus, hepatitis C virus, or hepatitis D virus in association with HBV, persisting for at least 6 months. In contrast to infection with hepatitis A or hepatitis C virus is usually self-limiting, and chronic hepatitis does not occur with E. The spectrum of disease following these infection ranges from self-limiting infection, mild to severe hepatitis, cirrhosis, and hepatocellular carcinoma. This chapter describes the epidemiology, clinical features, and diagnosis and treatment and prevention of these infections. Hepatitis B virus infection. Epidemiology. Hepatitis B virus has 42 nanometer virions with a 3200 base pair double-stranded DNA genome and is classified as Epidnavirus type 1. India has intermediate endemicity for this infection with a prevalence of 2 to 4% in the general population. Prevalence is higher in high-risk groups such as professional blood donors, patients on maintenance hemodialysis, thalassemia, and hemophilia. The viruses has 10 genotypes named as A to J. Genotype B is common in Asia and C in Asia and Pacific region. A in the USA and most of Europe, and D in the USA and Mediterranean regions. The genotype 1 has been identified in Laos and Vietnam, and genotype J in the Ryukyu Islands in Japan. The HPV genotypes appear to have a relationship with the mode of transmission. In East Asia, where vertical transmission is common, genotype B and C are more common by comparison. In India, genotypes D and A are more common and transmission is mostly horizontal, that is, by close physical contact during early childhood. Hepatitis B surface antigen positivity plateaus at 2 to 3% by 5 years of age and remains constant thereafter, whereas anti-HBs age positivity continues to increase with age because most chronic infections occur by 5 years of age, and exposure at older ages results in clearance of virus development of protective antibody. Transmission of HBV through breastfeeding is rare, that you must know. Natural history of chronic hepatitis B. Incubation period of HBV is 30 to 180 days with a mean of 60 to 90 days. Acute illness is usually mild or inapparent, with severe acute hepatitis or acute liver failure is only 0.1 to 1% of the cases. Progression to chronic hepatitis occurs in 95% of the neonates during vertical transmission. So incubation period is 30 to 180 days with mean of 60 to 90 days. That means mean is like 2 to 3 months. Acute illness is usually mild or inapparent with a severe acute hepatitis or acute liver failure in only 0.1 to 1% of the cases. Progression to chronic hepatitis occurs in 95% of the units during vertical transmission and in only 1 to 5% in adults. HBV is non-cytopathic and liver injury is caused by post-immune response. Table 1 shows the 5 stages of progression in chronic hepatitis B. However, patients may progress through these stages at different speeds, may stay in a stage for a long time, or may have a non-sequential progression. I want to see this table. So we have a spectrum where HBe Ag positive, that means active viral infection, and we have HBe negative, that means it's not an active infection but still infection is present because of HBs Ag positivity. So that will be your second stage, and resolved HBV infection where your HBs Ag is also negative. So whenever I work for a HBV infection case, I will send HBsAg, HBEG, and HBAg antigen and HBV DNA titers and ALT levels, and also will get the USG. Okay. So given that is the scenario, so what I have is in chronic infection with HBE antigen positive, okay, HBV DNA titers will be more than 10 raised to 7 international units per ml, whereas high or intermediate HBsAg positive, the HPV DNA titers are 10 raised to 4 to 10 raised to 7 international units per ml. What we should focus here is ALT will be normal, whereas here ALT will be elevated. Liver disease none or minimal in case of this HBV DNA more than 10 raised to 7, whereas moderate to severe already liver disease developed in this stage. Older term used to use immune tolerant phase for this high HBV DNA titers, immune reactive phase for HBe antigen positive phase used to use for this intermediate range. Indication for treatment in this stage not indicated. That means exceptions are we have to treat medical staff, pregnancy with possibility of transmission, we have to treat, and family history of HCC. So, immune tolerant phase, you can just wait and monitor and then see what's going to happen. Whereas this immune reactive phase, where HBe antigen is positive, okay, I have to treat. Then we have negative HBe antigen with low HBs Ag titers with less than 2000 international units per ml of HBV DNA titers with normal ALT, no liver disease. Previously, we used to term it as an active carrier stage, no need of treatment. Okay. And then we have intermediate level HbS-Ag titers with the negative HBe antigen with more than 2000 HBV DNA titers with elevated ALT, moderate to severe liver disease, HBeG negative chronic viral hepatitis is the previous term which we used to use. Here you have to treat. And then resolve HBV infection where HBsAg is negative, HBe antigen is negative, HBV DNA is undetectable, and then ALT is normal, liver disease is none, and HBsAg negative and HBC positive. That's what we used to tell. Once there is an infection in a person, anti-HBC will be positive for life. Okay, and here obviously treatment is not indicated. So these stages of chronic hepatitis B infection is something important. Okay. Acute hepatitis B, though we always treat it, as you know, hepatitis B. Acute HBV infection in adults is mostly self-limiting disease. It does not need any specific antiviral treatment. Follow HBsAg testing at 6 months is advisable. Continuing positive result indicates chronic infection. Patients with acute liver failure, protracted severe manifestations, or immunosuppressive state may benefit from specific inhibitors of HBV DNA polymerase. So, three things we have kept in mind: a severe disease in terms of acute liver failure, protracted severe manifestations, or immunosuppressive state person acquiring HBV infection. As we will treat by using HBV DNA polymerase inhibitors. These are lamivudine and tenofovir. Okay, so lamivudine and tenofovir. They'll have little side effects if any. Patients with chronic HBV infection need more detailed evaluation for determination of stage of the disease and need for antiviral treatment. So that's what they told in here. So we have immune tolerant phase where only selected people are treated, medical staffs, pregnancy with possibility of transmission, and families who have hepatocellular carcinoma. Let me stabilize this please. Okay. Whereas in immunoreactive phase where HBE antigen is positive, but HBV DNA titers are 10 raised to 4 to 10 raised to 7 here. What we have is ALT is elevated and there is moderate or severe affection of the liver. That's the reason we are treating here. Okay. After this, I want to proceed further and read each of the phases in detail. Immune tolerant phase or hepatitis B antigen positive chronic HBV infection. This stage is characterized by HBE antigen positive state, high rate of viral replication, and high serum viral DNA with little immune response. There is no immune response at all, resulting in very little hepatocyte injury, hence normal or mild elevated serum alanine transaminases. Thus, this is a highly replication but low inflammation stage. The liver histology shows none of mild necroinflammation, although integration of viral DNA into the host genome is present, and such patients are at risk of HCC. Next, I have immune clearance phase. Here, HBE antigen is positive. Okay, that you have to know. This phase is characterized by development of post-immune response. So, immune clearance phase is the term, which elicits necroinflammation in infected hepatocytes, elevated transaminase enzymes, and progression of liver injury due to healing with fibrosis over time. Due to partial immune clearance of infected hepatocytes, serum HBV DNA and quantitative HbSAg levels show a decline compared to the immune tolerant phase. The ALT level is high but can fluctuate and shows a weak correlation with grid of necroinflammation on histology. Over time, HB antigen is lost in 8 to 12% per year of patients with elevated ALT levels, and anti-HB seroconversion occurs, and with the 67 to 80% of such cases eventually becoming inactive carriers. This phase, there is immune clearance. The host immune response is acting, so that's the reason we are choosing to treat. Then we have inactive residual phase where HBe antigen is negative. So this next phase is characterized by loss of HBe antigen, reduced or absent echo inflammation, normal liver enzymes, and the low or undetectable HBV DNA levels less than 2000 international units per ml, and low serum HbS-Ag levels. Over time, some patients in this stage up to 1 to 3% per year show spontaneous HbS-Ag loss with a further reduction in the risk of progression of liver injury or development of HCC. Despite HBe antigen to anti-HBe seroconversion, 10 to 30% of individuals in this phase may have low-level chronic inflammation even after several years of inactivity. Zero reversion of HBe antigen can occur in about 4 to 20% of the person in this stage, suggesting that the stage is not inconsequential and needs regular lifelong follow-up. HBe antigen negative hepatitis. This stage may occur immediately after HBe antigen loss or through zero reversion after years of inactivity as indicated above. Majority of patients have mutations in this P4 or basal promoter region of HBV genome, leading to low or weak HBe antigen expression in absent or reduced. Okay. Resolved HBV infection. This stage is characterized by disappearance of HBsAg from blood, absence of detectable HBV DNA in serum, and appearance of anti-HBs antibody. And overall, 0.5% of patients with chronic HBV infection lose HBs antigen per year, mostly after HBV seroconversion. Since low level of HBV replication continues in livers for a few such persons, HBV DNA can be detected in liver tissue and the remaining is for cirrhosis and HCC. The clinical significance of this form of occult hepatitis is unclear. So we have HBV agent negative hepatitis. Hepatitis is what we are telling. This stage may occur immediately after HBV antigen loss or through seroconversion after years of inactivity. As indicated above, majority of the patients have mutations in the P4 or basal promoter region of HBV genome, leading to lower HBV antigen expression is observed reduced. So I finished Jamaica first Pomodoro. I will happily write. Today I'm planning to study really nicely until how my plan goes. I don't want to waste time today. In fact, my plan is to do 3 sets of 3 Pomodoros of 40 minutes each. Now I'll go off.